everyone. It's really a pleasure this morning to introduce Dr. Hiddo Lambers Heerspink, who's an old friend and colleague, and we're so thankful that he has given us time this morning to give medicine grand rounds. Hiddo is from Groningen in the Netherlands and is zooming in from across the pond. And so it's very nice that at least that aspect of the COVID pandemic allows us to really bring in world experts for exciting talks from across the world without all the travel. And so really excited about that opportunity. I just want to say a few words about Hiddo before his presentation. It's really been terrific to not only watch the impact of his work, but also watch his career, which has been truly in an exponential rise, really on the international stage. So not too long ago, in 2012, Hiddo took his first position as assistant professor. And over the past decade, as I mentioned, his work and his recognition has just really skyrocketed. He is now a professor of clinical pharmacy and pharmacology at the University Medical Center in Groningen in the Netherlands. And he's also spent several years, first as a postdoc and more recently as faculty with a joint appointment at the George Institute in Sydney, Australia, which has been a leading center for clinical trials, particularly in nephrology, that are conducted across the world. Hiddo has really focused on diabetic kidney disease in all of its permutations, and has really been at the forefront of leading several important clinical trials, particularly around SGLT2 inhibitors. And as many of you know, these drugs have had incredibly important effects, not only on cardiovascular disease, but also on the prevention of chronic kidney disease. And I'll venture to say that in my career, that the new discovery of a drug that's well tolerated and taken once per day and can lower the risk of end-stage renal disease by 30 to 40% is perhaps the most important medical advance that we've seen in nephrology in the past 20 years. And Hiddo's really been at the forefront of that in the trials that he's led. He was the chair of the DAPA-CKD study, which I'm sure we'll hear a little bit about today. He led or was on the steering committee for the Credence trial, as well as the SONAR trial. And he's also had a key role in key meetings with the FDA, where he has evaluated existing data to try to establish more sound surrogate endpoints to increase the amount of drug development and discovery for chronic kidney disease. Despite only being about 10 years into his faculty career, he has almost 300 peer-reviewed manuscripts and is really, as I mentioned, leading this area internationally. And so it's really a pleasure to have you with us today, Hiddo, and look forward to your talk today, in particular about how these new drugs may actually go beyond diabetic kidney disease and what we can expect in the future. Thank you so much, Hiddo.
Thank you so much, Joe, for this introduction. I almost feel a little bit embarrassed when I hear all of this. Thank you, everyone, for the invitation. And it's my pleasure to be with you this morning and talk about kidney protection in 2021 and beyond. So what can we expect in the near future with all these developments that Joe already mentioned? See if I can advance the slide. It's funny. It's never occurred to me that the slides do not advance. Yeah, here they go. So my disclosures are listed here. I collaborate with a number of pharmaceutical companies, and perhaps important to note in this respect is that I work together with AstraZeneca, the sponsor of the DAPA-CKD trial, one of the trials I will be reviewing. As you know, the number of patients with kidney replacement therapy will increase in the coming decade. These are data on the left from a publication published a few years ago in The Lancet, demonstrating that in particular in North America and in Asia, the number of patients receiving kidney replacement therapy will increase. We also know that the number of patients who die from kidney disease have increased from 2007 to 2017 by 1.5%. And when we compare that with other chronic diseases like ischemic heart disease or COPD, this is a quite marked increase, because for the other diseases we see a decreasing number of mortality due to these diseases. So these facts together indicate that we need new treatments for chronic kidney disease. And not only diabetic kidney disease, but also non-diabetic chronic kidney disease. In addition, cardiovascular complications are frequently occurring in patients with chronic kidney disease or diabetic kidney disease. And these are 3 trials that have been conducted in the past with angiotensin receptor blockers or renin inhibitors, demonstrating that heart failure is the most frequent occurring cardiovascular complication in these patients with diabetic kidney disease. So we need new drugs to slow the progression of kidney disease, to prevent dialysis, and to prevent, in particular, heart failure, but also the other cardiovascular complications. So what have we done over the last 2 decades? Well, this is just these are a number of clinical trials that have been conducted in patients with type 2 diabetes, without diabetes, as well as patients with type 1 diabetes. And what you can directly see from the slide is that the dark blue bars, the patients with diabetes, these are most well studied in all these trials. The trials are larger because along the y-axis you see the size of each trial, and there are more clinical trials compared to patients, the trials done in patients without diabetes, the light blue bars, or type 1 diabetes, where there's only 1 clinical trial, captopril. We do have 2 other trials in type 1 diabetes, or at least 1 with a uric acid lowering drug, but clearly type 1 diabetes is also understudied, as is non-diabetic kidney disease. So most of the focus has always been on type 2 diabetes, but there we see that many trials actually failed to show a beneficial effect of the intervention that was studied, and most trials were actually terminated early because of safety issues. So what were then the successful trials? Of course, we had in the late 90s and early 2000s the ACE inhibitors and angiotensin receptor blockers, and some of them led to a new drug registration. And then in 2019, the Credence trial and the SONA trial were published, demonstrating in the Credence trial that the SGLT2 inhibitor canagliflozin protects the kidney, and in the SONA trial, the endothelin receptor antagonist atrasentan protected the kidney. So suddenly, after 20 years of lack of innovation, in 1 year, we had 2 new drugs, canagliflozin and atrasentan, demonstrating that on top of ACE inhibitors, angiotensin receptor blockers, we can protect the kidney. Last year, we heard the results of the DAPA-CKD trial, demonstrating that dapagliflozin in patients with chronic kidney disease protects the kidney. And then at the end of last year, the Fidelio trial, demonstrating that finerenone, a mineralocorticoid receptor antagonist, also reduces the risk of end-stage kidney disease. So finally, after years of waiting, we have new drugs, different drug classes that have been shown to be successful in slowing the progression of kidney disease. If we look at the drugs that have a label for kidney protection, there's actually not many drugs that have that label. Losartan and irbesartan, based on the RONAL IDNT trial, have received a label for kidney protection in type 2 diabetes. But if we look in the non-diabetic disease area at the bottom, there's actually only 1 drug that has a label for kidney protection, and that's ramipril in patients without diabetic kidney disease who have a proteinuria level of more than 3,000 milligrams per gram. So if you are prescribing an ACE inhibitor to a patient without diabetes and kidney disease, you're probably prescribing that off-label, because the ramipril has only a label for kidney protection in Europe and not in the United States. But we believe, and I think that's right, that both ACE inhibitors and angiotensin receptor blockers are kidney protective. But if you just look at the label, it's only ramipril that has that label, and that's based on the RAIN study, the study conducted in Italy. Now in 2016, as you know, the EMPA-REC trial demonstrated that empagliflozin in patients with established cardiovascular disease also reduced the risk of a kidney endpoint, a doubling of creatinine in end-stage kidney disease or kidney death. This was not expected because if you look at the protocol from the EMPA-REC outcome trial, they had a whole list of secondary outcomes. And only the last secondary outcome was the kidney outcome. But still, they found this huge effect. Some people say, well, this can be a chance finding, but clearly it's not, because 1 year later, in 2017, the CANVAS program demonstrated in a population, again, at cardiovascular risk with a GFR of around 75 mL per minute, that canagliflozin also protects the kidney. And 1 year later, in the DECLARE trial, similar results were found. All these studies included patients with relatively preserved kidney function. And the CREDENCE trial, I already mentioned it, showed that canagliflozin in patients with established kidney disease and type 2 diabetes also reduced the risk of end-stage kidney disease, kidney death, or doubling of creatinine. Since the publication of the EMPA-REC outcome trial, many people, including myself, started to speculate what the pathways for kidney protection could be. And some people believe that the reduction in blood pressure and improvement in endothelial function can play a role. Others believe that SGLT2 inhibitors improve oxygenation in the proximal tubule and thereby prevent kidney progression. And again, other people believe that these drugs reduce intraglomerular pressure and thereby restore tubuloglomerular feedback, reduce glomerular hyperfiltration, and thereby protect the kidney. And I actually believe that that is one of the main pathways for kidney protection. And the reason why I believe that is that we know also that ACE inhibitors, angiotensin receptor blockers are powerful kidney protective drugs and also reduce glomerular hyperfiltration. And they do that in patients with and without type 2 diabetes. And I believe that it is well established both in experimental as well as in clinical studies that SGLT2 inhibitors reduce intraglomerular pressure and restore tubuloglomerular feedback. This mechanism of action leads to an acute reduction in GFR because if we reduce glomerular hyperfiltration, that directly translates into an acute reduction in GFR, just like we've seen with ACE inhibitors and angiotensin receptor blockers. This is seen in the CREDENCE trial as well. After 3 weeks of treatment, there was a reduction of about 4 mL per minute in GFR. That initial reduction is followed by a complete stabilization of renal function decline, such that during prolonged treatment, we are able to reduce the rate of eGFR decline by 60% compared to placebo. A huge effect and much more than what we have seen with ACE inhibitors or angiotensin receptor blockers. Initially, this reduction in GFR caused some concern. People felt uncomfortable. They were thinking that they were causing renal injury. But nowadays we know that it should not lead to a concern. It is just reflecting the mechanism of action and an indication that the patient is taking the medication and is drug adherent. So we know that ACE inhibitors, angiotensin receptor blockers, cause vasodilation of the efferent arteriole, thereby reduce diabetes-related glomerular hyperfiltration, and thereby reduce the pressure in the kidney, and in the long term, that stabilizes kidney function. SGLT2 inhibitors, on the other hand, block the sodium glucose transporter in the proximal tubule, thereby increase the delivery of sodium to the distal tubule, and that downregulates tubuloglomerular feedback signals. In patients with type 1 diabetes, at least, that leads to a constriction of the efferent arteriole, and thereby a reduction in renal blood flow, a reduction in glomerular pressure, glomerular hyperfiltration, and an acute decline in GFR, which in the long term is associated with stabilization of kidney function. I specifically mentioned in type 1 diabetes because there are 2 studies that have also looked at the effects on glomerular hemodynamics in type 2 diabetes, and these studies actually demonstrated that SGLT2 inhibitors in patients with type 2 diabetes cause vasodilation of the efferent arteriole on top of an ACE inhibitor or angiotensin receptor blocker. So while the initial hypothesis is that in type 1 diabetes these drugs cause afferent constriction, in type 2 diabetes it may be different. But whatever the mechanism is, in the end we reduce glomerular hyperfiltration and thereby protect the kidney. Could this effect also play a role in patients without diabetes? Well, there are very old studies published already in the early 90s demonstrating that patients with hypertension are also hyperfiltering, and that hyperfiltration is associated with an increase in sodium reabsorption or decrease in proximal tubal sodium reabsorption. Sorry, I should say increase in proximal tubal sodium reabsorption. If you look in the graph on the left, you see control patients denoted by C have a GFR of around 100, hypertensive patients who were not hyperfiltering, and then on the right, the hypertensive patients who were filtering. If we look at the lithium clearance of these patients, we see that the lithium clearance in patients who were hyperfiltering and had hypertension is decreased. And a decrease in lithium clearance actually indicates an increase in sodium reabsorption in the proximal tubule, just like what is happening in patients with type 2 diabetes who have more sodium glucose transporters, because these patients try to keep the glucose that is filtered in the body and thereby upregulate the sodium glucose transporter. A similar phenomenon is happening in these hypertensive patients, and they also reabsorb more sodium, and thereby there's less sodium delivery to the distal tubule and to the macula densa, and that may then lead to a increase in renal perfusion, because the macula densa senses this as an underperfusion and thereby dilates the afferent arteriole. This hyperfiltration in patients with hypertension is associated with a higher risk of developing of microalbuminuria, as shown on the right. The light blue bars are patients with who are hyperfiltering, and you can see that if we follow these patients over time, there's more patients who develop microalbuminuria as one of the first manifestations of kidney damage. So this phenomenon of hyperfiltration is present also in patients without diabetes, and the same is true in obese individuals. Studies have shown a clear association between BMI and filtration fraction, such that at higher BMI there's a higher filtration fraction, indicating more glomerular hyperfiltration. And the same is seen if we compare obese individuals with control patients with a relatively normal GFR. These obese patients have a higher GFR and are a higher filtration fraction, indicating that they are hyperfiltering. Now, if SGLT2 inhibitors reduce hyperfiltration, would then these drugs also be effective in patients without diabetes? So what do we know about glomerular hyperfiltration in different causes of kidney disease? Well, we know that in hypertensive nephrosclerosis, there's arterial stiffening leading to an increase in renal plasma flow and a higher intraglomerular pressure. The same is true for obesity-induced chronic kidney disease or secondary focal segmental glomerular sclerosis. And of course, the same is true, happens also in diabetic nephropathy. So all these different causes of kidney disease drive to a common pathway, namely glomerular hyperfiltration, that leads to kidney damage. Thus, we felt that an SGLT2 inhibitor could well be efficacious in patients without diabetes. And that's why we designed in 2016, before the publication of the Canvas Declare Credence trial, the DAPA-CKD trial. And we enrolled in this trial patients with chronic kidney disease with and without diabetes. And we compared this effect of dapagliflozin to placebo and asked the question whether dapagliflozin could reduce the risk of a kidney and cardiovascular outcome and prolong survival. So the primary outcome was a 50% eGFR decline, end-stage kidney disease, renal or cardiovascular death. And the secondary outcomes were a kidney-specific outcome defined in the same way as the primary, but excluded CV death, heart failure hospitalization or CV death, and all-cause mortality. The trial enrolled patients, adult patients with a GFR between 25 and 75 in high albuminuria, and we excluded patients with type 1 diabetes, polycystic kidney disease, lupus, ANCA-associated vasculitis, and those who receive immunosuppressive treatment, because we felt that the drug would not be safe enough or efficacious enough in these patients. And these were the results. The primary outcome was reduced by 39%. The secondary kidney-specific outcome reduced by 44%. The cardiovascular outcome, defined here as heart failure hospitalization, cardiovascular death, reduced by 29%. And I think most notably, all-cause mortality was significantly reduced by 31%. And these data have been published before, and you have probably heard about them. What I would like to do in this presentation is give you some insight on new results from the dapagliflozin trial. And most of the data that I will be presenting now is just published or will be published in the next few weeks. So let's first take a look at patients with and without diabetes. So in the cohort, we had 68% of patients with diabetes and 1/3 of patients without type 2 diabetes. Now, if we look at the patients with diabetes, and we look at the underlying cause of kidney disease, we see that among those with diabetes, the majority had diabetic nephropathy. But there were also some patients with diabetes who had glomerulonephritis, ischemic hypertensive nephropathy, or other or unknown causes of kidney disease. If we then look at the effect of dapagliflozin in patients with and without type 2 diabetes, for the primary outcome, we see consistent results. Both dapagliflozin was both effective in patients with and without type 2 diabetes, and the p-value for interaction suggests that the primary outcome is not different in these two subpopulations. And the same is true for the kidney-specific outcome. Dapagliflozin reduced this risk both in patients with and without type 2 diabetes. Similar findings were observed for the cardiovascular death, heart failure hospitalization outcome, although it was not significant in patients without type 2 diabetes. But if we look at the number of events, 15 and 19, there were only few of these cardiovascular events in patients without type 2 diabetes. And then all-cause mortality was also reduced in patients with and without type 2 diabetes, with no evidence that the effect was different between the two subgroups. Now, if we look more carefully, and this data will be published in the next couple of weeks in Diabetes Care, if we look at more carefully at the effect of dapagliflozin as a function of baseline hemoglobin A1C, we actually see that the results are super consistent. Across the range of HbA1c values, dapagliflozin reduced the risk of the primary outcome. And this suggests that the effect of dapagliflozin is clearly not driven by improvements in glycemic control. We did further analysis and we found that in patients without diabetes, there was no reduction in HbA1c, 0%. In patients with type 2 diabetes in the DAPA-CKD trial, there was only 0.1% reduction in HbA1c. Again, indicating that these drugs, although they were initially developed as glucose-lowering drugs, they have many other effects, and these other effects explain their profound effects in preventing kidney and cardiovascular outcomes. Now, in the trial, we enrolled patients with diabetic nephropathy, ischemic hypertensive CKD, glomerulonephritis, and a number of patients in whom the cause of kidney disease was unknown. When we look at the primary and secondary outcomes by CKD etiology, overall, we have no evidence that the effect of the drug varies among these different causes of kidney disease. Of course, the point estimate varies a little bit, but the confidence intervals are wide. And if you look at the p-value for interaction, they are all non-significant, indicating that we have no evidence to suggest that the results are different in any of these subgroups. The glomerulonephritis is, I think, an interesting subgroup because some people say, well, the effect may be higher in those subgroups, because if you look at all these four different endpoints, the point estimate always favors the glomerulonephritis, and that may be true. We just presented at the WCN an analysis of the 270 patients with IgA nephropathy. This was the largest subgroup within the DAPA-CKD trial with a single cause of disease. In that subgroup of 270 patients, dapagliflozin reduced the risk of the primary outcome by 71%. And these results have just been published in Kidney International and demonstrates even that in people with a relatively small cohort, dapagliflozin can still significantly reduce the risk of the outcome and slow the progression of disease. Now, we were also interested to look at the effect of dapagliflozin in patients with stage 4 chronic kidney disease, or GFR below 30. Remember that all the guidelines and all the labels for all the SGLT2 inhibitors do not recommend to initiate an SGLT2 inhibitor in stage 4 chronic kidney disease. In the DAPA-CKD trial, there were 624 people who had stage 4 CKD. And if we look at their characteristics and compare those with stage 2 or 3 chronic kidney disease, we see that in particular, the albuminuria at baseline is higher in patients with chronic kidney disease stage 4. And of course, the GFR is lower, around 27, compared to 46 in stage 2 or 3 CKD. But if you look at the proportion of patients with type 2 diabetes or those with cardiovascular disease, these numbers are generally similar between stage 4 or stage 2 or 3 chronic kidney disease. Now, the effect of dapagliflozin in stage 4 chronic kidney disease was consistent with the effect in stage 2 or 3. And this held true for the primary endpoint, which you can see at the top of this forest plot, but was also true for the secondary kidney composite outcome, the cardiovascular death outcome, or all-cause mortality. So in this population, dapagliflozin also prevents kidney and cardiovascular outcomes, just like it does in people with stage 2 or 3 chronic kidney disease. Then when we look at the eGFR decline, we again see similar results in stage 2, 3 chronic kidney disease or stage 4 chronic kidney disease. And we again see this typical pattern that we always see with an SGLT2 inhibitor, an acute decline in GFR followed by a stabilization of the long-term eGFR trajectory. Well, if we carefully look at the acute effect in patients with stage 4 or stage 2 or 3 chronic kidney disease, and you can see that in the table at the bottom of the slide, you'll see that the acute effect is higher in patients with stage 2 or 3 chronic kidney disease. This is clinically important, I believe, because if you initiate an SGLT2 inhibitor in stage 4 chronic kidney disease, you don't have to be afraid that the acute effect is so large that the patient directly requires dialysis. I think that the mechanism for this reduction in acute effect is that there are fewer functioning nephrons in patients with stage 4 chronic kidney disease. So within a single nephron will still reduce glomerular pressure, glomerular hyperfiltration, but because there are fewer nephrons in stage 4 chronic kidney disease, total GFR reduction is less in these patients. If we look at the rate of decline during the chronic phase of the trial, you can see that in the table below, the effect of dapagliflozin is the same in patients with stage 4 or stage 2 or 3 chronic kidney disease. And then if we look at the total effect, and then we combine the acute and chronic effect, of course, because the acute effect is smaller in patients with stage 4 chronic kidney disease, the total effect is a little bit better in stage 4 compared to stage 2 or 3 chronic kidney disease. Now, what about mortality? Mortality is frequently occurring in patients with chronic kidney disease, and worldwide there are more than 1 million people per year dying because of chronic kidney disease. In the DAPA-CKD trial, the main causes of death were sudden cardiac death, infections, malignancies, and there were a number of patients in whom the cause of death could not be determined. Now, when we look at the effect of dapagliflozin on mortality, I already mentioned the overall effect, a 31% relative risk reduction compared to placebo in the top row. If we look at cardiovascular death, there was no statistical significant reduction, 0.82 hazard ratio with a confidence interval that crosses 1. That effect size is almost identical to the effect size which was observed in the Credence trial. There we found a hazard ratio of 0.80, but was statistically significant, most likely because they had many more cardiovascular deaths compared to our trial. When we look at non-cardiovascular deaths in the DAPA-CKD trial, we found a significant reduction of 46%, and that reduction was mainly driven by fewer deaths due to infections, malignancies, and renal failure. And I think the malignancies are of interest. We nowadays know that from animal models that SGLT2 transporter is expressed in tumors. And we also know from experimental studies in cancer that SGLT2 inhibitors may slow tumor growth. And there are now even a couple of clinical studies looking at the effects of SGLT2 inhibitors in certain types of cancer. That's an interesting new area that some people are exploring. Where does this lead us? I started off the presentation by showing the cardiovascular primary outcomes of the DECLARE study conducted in patients with type 2 diabetes and chronic kidney disease. Of course, in the DECLARE study, there were also kidney events collected. And dapagliflozin reduced the risk of end-stage kidney disease or kidney death by 46% in this trial, mainly in patients with a GFR above 60. Now, in the DAPA-CKD trial, we demonstrate that in patients with established kidney disease, dapagliflozin also protects the kidney. So it appears that dapagliflozin is effective across the continuum of eGFR and across the continuum of albuminuria levels. And I believe that that's the reason why the FDA last week approved dapagliflozin for the treatment of chronic kidney disease. And this is the press release that was issued by the FDA with a statement from Elisa Thompson saying that today's approval of dapagliflozin is an important step forward in helping people living with kidney disease, and I would agree with that statement. If you look at the label, there is no threshold for initiating dapagliflozin based on albuminuria. And I believe that the reason is that the FDA also looked at the trials in combination. So the FDA did not only look at DAPA-CKD, but looked at the DECLARE trial, the DAPA-CKD trial, and felt it was appropriate to give a label for kidney protection across the range of albuminuria and GFR values. Now, what about the other trials? We should not forget about the other trials, of course. Fidelio DKD was a trial that looked at the effect of finerenone, and it demonstrated that finerenone also reduced the risk of 40% eGFR decline, end-stage kidney disease, or renal death. Finerenone also slowed the progression of kidney function decline. And again, we see this characteristic dip in GFR, which we also saw with SGLT2 inhibitors, although the effect is a little less. And then during prolonged treatment, we see a stabilization and less eGFR decline with finerenone compared to placebo. So it appears, and we know that already, that finerenone also reduces intraglomerular pressure because it's just like an ACE inhibitor angiotensin receptor blocker causing efferent vasodilation. The problem with a mineralocorticoid receptor antagonist is that it causes hyperkalemia. That was also observed in the finerenone trial. In the trial, there were more patients who had a treatment emergent adverse event of hyperkalemia. But if we look at the treatment emergent hyperkalemia adverse events with clinical consequences, so those leading to permanent drug discontinuation or those leading to hospitalization, the numbers were low, although there were more patients on finerenone that had a treatment emergent adverse event with clinical consequences. None of these adverse events, however, led to death. Another important trial is the SONA trial. The SONA trial demonstrated in 2019 that the endothelin receptor antagonist atrasentan reduced the risk of kidney failure. And you can see that on the left with a hazard ratio of 0.65. However, the problem with endothelin receptor antagonists is that they cause fluid retention, which may lead to heart failure. And this was also seen in the SONAR trial. You can see it on the right. The hazard ratio for heart failure is 1.4. It was not significant, but I should say that the trial was stopped early. And maybe if the trial would have lasted longer, there were more patients on atrasentan with heart failure and the effect size would have been statistically significant. So how does then the future look like? Because suddenly after the ACE inhibitors, angiotensin receptor blockers, we have multiple drugs that we can prescribe. We can prescribe SGLT2 inhibitors, we can prescribe mineralocorticoid receptor antagonists, we can prescribe perhaps even endothelin receptor antagonists. And the question will be, which drug should be prescribed to which patient? Well, maybe we should even take it one step further and say which combination of drugs should we start using? Well, if we think about the combination of a mineralocorticoid receptor antagonist and SGLT2 inhibitors, it's important to note that SGLT2 inhibitors actually reduce the risk of hyperkalemia. And this is nicely seen in the EMPA-REC outcome trial in patients with type 2 diabetes, established cardiovascular disease, a significant risk reduction for hyperkalemia. In the CANVAS trial, there was a reduction in the risk of serious hyperkalemia, but there were few events and the effect size was not statistically significant. In CREDENCE, there was a reduction in the risk of hyperkalemia. In the DAPA-HF trial, which was a trial in heart failure patients with dapagliflozin, there was also a reduction in hyperkalemia. So maybe we can, and then finally in the SOLARIS trial, which is a trial with sotagliflozin, there was also a reduction in risk of hyperkalemia. So maybe we should start combining an SGLT2 inhibitor with a mineralocorticoid receptor antagonist in order to augment kidney protection and at the same time mitigate the risk of hyperkalemia. And that's why we conduct this proof of concept study in patients with chronic kidney disease. We actually started a little while ago already testing the SGLT2 inhibitor dapagliflozin, the MRA eplerenone, and the combination to assess whether the combination reduces albuminuria more than the single agent and also reduces the risk of hyperkalemia. We will finish the study in the next few months, and we hope to present this data at the end of this year. And then what about the combination of an SGLT2 inhibitor with an endothelin receptor antagonist? I already mentioned that an endothelin receptor antagonist may cause fluid retention, and SGLT2 inhibitors, at the other hand, may have diuretic effects. So could we again use a combination where we increase kidney protection and further reduce albuminuria, but at the same time mitigate the risk of fluid retention by adding the SGLT2 inhibitor? Now, in the SONAR trial, there were a couple of patients, 14 patients in total, who started an SGLT2 inhibitor at the same time when they were randomized in the study and started atrasentan. When we matched these 14 patients with 42 control patients who were only starting atrasentan alone, we found that there was an increase in body weight reflecting fluid retention in the atrasentan patients. But when we combined it with an SGLT2 inhibitor, we saw a reduction in body weight and a reduction in BMP, indicating that these patients do not retain fluid induced by atrasentan. If we then look at the albuminuria response on the right, we see that we further reduce albuminuria with the combination as expected compared to the single agent. And also when we looked at blood pressure, not shown on the slide, there was a further reduction in blood pressure compared to atrasentan alone. So perhaps we should conduct clinical trials starting combining endothelin receptor antagonists and SGLT2 inhibitors to maximize kidney protection and minimize heart failure. So our current treatment of ACE inhibitors and angiotensin receptor blockers are insufficient to slow CKD progression. I've shown you that the SGLT2 inhibitor dapagliflozin reduces the risk of kidney failure, heart failure, hospitalization in patients with and without diabetes. The protective effects are unrelated to improvements in glycemic control and are, at least in part, attributed to reduction in glomerular hyperfiltration. Other effective therapies are endothelin receptor antagonists, atrasentan, mineralocorticoid receptor antagonists, finerenone, but they are associated with side effects, hyperkalemia, fluid retention, and thus finding the optimal combination is essential. And then we have to look in the future and define the optimal combination for individual patients. We have studied overall more than 70,000 people now with SGLT2 inhibitors in all these clinical trials. And all these clinical trials demonstrate that these drugs reduce heart failure and kidney failure. I believe there's enough evidence. There's enough evidence that these drugs are safe. And it's now up to us to implement these trial findings in clinical practice. And I believe that that is our responsibility. It's my responsibility to present these findings to many people. It's your responsibility and my responsibility to prescribe these drugs to individual patients. And I know that's not always easy. In particular in the United States, where patients have to pay these drugs for themselves. That's not the case in the Netherlands. In the Netherlands, it's paid by the insurance. It's a little bit easier. And I understand that sometimes these drugs are expensive. So there's also a role for pharmaceutical companies to make these drugs available, in particular in low middle income countries. So it's a joint responsibility, but I hope we can implement these trial findings in clinical practice. Thank you for your attention.
Wonderful, Hiddo. That was a really terrific presentation, and I really thank you for putting it together and teaching us. If anyone has questions, please go ahead and put them in the Q&A section, and I'll do my best to get through them. We have one here already from Dr. Carl, who's a nephrologist here at UCSD, who speaks to the question you asked or mentioned at the end. The difficulty that we sometimes have in getting these drugs approved for our patients, particularly, I guess, for non-diabetic proteinuric patients. So I guess the question is this a class effect, or do you think it's important that patients get DAPA specifically? And in what indication, if one is needed over another, when to be specific?
Yeah, fantastic question. To be honest, I believe these drugs exert a class effect. If you carefully look at the molecular structure, and then if you compare empagliflozin and dapagliflozin, their molecular structures are similar. In particular, the part of the molecule that binds to the transporter is the same. Canagliflozin is a little bit different. Canagliflozin has a slightly different structure. But if we look at the surrogate outcomes, the blood pressure effects, the body weight effects, the HbA1c effects, they are generally similar. However, if I have to prescribe a drug, I would always prescribe the drug with a proven evidence. So for dapagliflozin, we have evidence that the drug is safe, effective in diabetic and non-diabetic kidney disease. That's why my preference would be to prescribe dapagliflozin for patients without diabetes and chronic kidney disease. But for example, for patients with diabetes, you could choose between Cana and DAPA. If there's no other option and you have to prescribe empagliflozin, I think it's fair to prescribe empagliflozin. If we look at the heart failure trials, dapagliflozin and empagliflozin showed identical effects. But we don't have evidence yet for empagliflozin, although there is a trial ongoing, which will be finished by the end of the year.
Great. Dr. Rifkin, another nephrologist here at UCSD, firstly, thanks you for your superb work. And mentions that often the EGFR decline that's seen acutely is an immediate concern for the clinician, and wondered if you had any practical advice about how to get past that, or any ways to monitor that. Perhaps the question may be, in the protocols of these trials, was there any bump in creatinine or drop in EGFR that was protocolized by which to come off drug, and how much of a change should clinicians tolerate before concern should be raised?
Yeah, really important questions. And I'm going to share a slide, and I'm doing that because I think it's so important to show these results, because I think they answer this important clinical question. This is an analysis that we recently published in Kidney International from the Credence trial, where we stratified patients according to their initial change in GFR. So there were about half of the patients on the left, shown on the left here, that's the canagliflozin group, and on the right you see the placebo group. On the left, there were about half of patients with a decline in eGFR more than 10%. And then there were about 25% of patients with a GFR change from baseline to week 3 between 0 and 10%, and 25% with an increase. If we look at the long-term eGFR trajectories, they are similar. So whatever you irrespective whether you had an increase or decrease in eGFR, your long-term eGFR trajectory during canagliflozin was identical. Importantly, if you look at on the right in the placebo group, and when we use the same categories of eGFR change, there was no difference among the 3 placebo strata. But the long-term eGFR trajectory in the canagliflozin group was always less compared to placebo. And thus, I don't think that this initial dip in GFR should raise concern about subsequent acceleration of renal function decline. Also, when we look at side effects, there was no increase in side effects if the GFR fell by 10, 20, 25%. Only in a few patients where the GFR dip was more than 30%, there was a slightly higher risk for renal-related adverse events. So how should we deal with this in clinical practice? Should we monitor eGFR after initiation of an SGLT2 inhibitor? David Chern and I recently wrote an opinion article about this in CJSON, and you can read it on the website in CJSON. And we think that it is actually not necessary to do, because in our experience, often we measure and often it doesn't lead to any clinical change or change in management of the patient. And thus we think that it is not necessary. We're asking patients to come back in the clinic after a few weeks. We take a blood sample, but then the clinical management doesn't change. So that's why we think that for the average patient, it isn't necessary. Of course, there are certain patients where you would like to do it. The elderly, frail patient who is already on a high dose of a diuretic and an ACE inhibitor, when it's summer, or when the patient has other diseases, you can definitely consider to monitor more closely eGFR. But for most of the patients, it is actually not necessary. I hope this answers your question. And then the final question, was there a protocol related demand to stop the SGLT2 inhibitor? And the answer is no. In none of the trials, SGLT2 inhibitors were stopped because of the initial change in GFR.
Wonderful. I think the slides are really helpful. Thank you. Dr. Insel asks, do SGLT2 inhibitors decrease the risk of hyperkalemia in studies with ACE and ARBs?
The answer is yes. In the Credence trial, all patients were on an ACE inhibitor or angiotensin receptor blocker. And in that population, hyperkalemia defined as a potassium more than 6 was reduced by 20%. Hyperkalemia defined as investigator-reported hyperkalemia was also reduced by about 20%.
Great. A specific question about an individual patient. Would you consider using SGLT2 inhibitors in an elderly male with a GFR of 25 due to about 40 years of PLA2R mediated glomerulonephritis? So I presume membranous nephropathy and proteinuria in that setting.
Yeah, these are the patients that we studied and where we also showed beneficial effects. So I would consider initiating an SGLT2 inhibitor.
Wonderful. I guess related question, if I can ask, in the studies where you looked at subtypes of causes of kidney disease, how was that defined? Were they all receiving biopsies, or was that in the subset of patients that had biopsies or clinical diagnoses?
So the protocol didn't demand a biopsy. So these were investigator reported causes of kidney disease. In the IgA population, 96% of patients had a biopsy. and a biopsy-proven IgA nephropathy. In patients with FSGS, for example, 92% of patients had a biopsy-proven FSGS. So where for the populations where you think there are many patients with a biopsy-proven cause of disease, that's true. But of course, for example, for diabetic kidney disease, which we typically don't biopsy, there were not many patients who had a biopsy confirmed diabetic kidney disease.
Okay, wonderful. Now here's a specific question from Dr. Turkeltaub, one of the rheumatologists here at UCSD. And Bob, I hope I get your question right. So please unmute if I get it wrong here. Can you discuss the precision and pharmacogenomics considerations? Are there any links with ABCG2 variants which model or modulate handling of uremic toxins indoxyl sulfate? I ask because SGLT2s lower serum urate, but not sure of the impact of that.
Hi, Bob. Fantastic question, but you're making it me very difficult. I've looked myself at and I was hoping that you went in that direction. I've looked at polymorphisms in the SGLT2 transporter gene, and we're currently working on that. There are a few polymorphisms in the SGLT2 gene, and there's some evidence that they may influence the blood pressure response to an SGLT2 inhibitor, but these are based on small studies. And fortunately, we have been able to collect DNA in DAPA-CKD, so we're exploring that in more detail. Regarding your question of the ABCB2 transporter, I have no idea. I know there are polymorphisms, but certainly worth further exploring, I think. Maybe you could email your question to me, because this is something that we could probably also do in DAPA-CKD, and happy to work with you on that.
Thanks, Hiddo. I mean, outstanding lecture. My question is partly because some of these dysfunctional ABCG2 variants are very, very common in South and East Asia, also in Mexican Americans. And so that's part of the precision, especially in Southern California.
Yeah, very interesting. Yeah, and we have a global trial, and certainly worth exploring.
Okay, Hiddo, a question from Volker Valen. You may know Volker Valen and Scott Thompson are nephrologists here who do a lot of micropuncture and have worked on tubular glomerular feedback.
Yeah, I read all their papers.
Yeah. Dr. Valen asks, first, thanks for the excellent talk. He says, Scott Thompson and I just published micropuncture studies in rats. The reduction in GFR in response to SGLT2 inhibitors can underestimate the reduction in glomerular capillary pressure, which could be relevant in advanced CKD, where the initial GFR is less, but organ protection is preserved. And the studies indicate an effect on the afferent and efferent arterioles in rats with type 1 diabetes consistent with a dual effect.
Yeah, I saw that publication and I read it with a lot of interest. I'm not an experimental scientist, so sometimes it's a little difficult for me to grasp everything what you published for Volker. But certainly, and if I understand correctly, you would suggest that even in advanced disease, there's more efficacy. And it may be of interest for you to know that we are starting a new clinical trial looking at patients with end-stage kidney disease, so GFR below 15, and we're even going to assess the effects of dapagliflozin, hopefully, in patients with dialysis, who are already on dialysis with residual diuresis. So this will be hopefully the next step, because we have excluded patients in all the trials with GFR below 20. And we believe that SGLT2 inhibitors could also be effective in these patients in preventing, for example, mortality or further disease progression.
Hiddo, maybe I can insert a question because it's relevant to who gets these drugs in the clinic. Right now, to my knowledge, unless it changed last week, SGLT2s are limited to patients with an eGFR greater than 30. And I presume that's because of lack of phase 3 trial data about patients with lower eGFR. Can you tell us about any movement at FDA or otherwise to expand that to lower levels of eGFR? Is that happening, and what will it take? And I might ask a second question. if you could say a word about the safety of SGLT2 inhibitors in the non-diabetic setting in terms of glycemic control. Is there any hypoglycemia and is there any concern there?
Yeah. So for your first question, this is going to change, has changed since last week. Dapagliflozin can be prescribed in patients with the eGFR down to 25. Dapagliflozin can be continued. You don't have to stop when the GFR is below 25. You can continue all the way to dialysis. In fact, in the DAPA-CKD trial, we just continued dapagliflozin even when patients were on dialysis. And although it's not randomized, if we look in the dialysis population, and the follow-up is short and there's a lot of caveats, blah, 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 but there were fewer deaths in the dapagliflozin group in those who were on dialysis compared to placebo. So I think this is going to change, and the EMPA kidney trial is studying patients with a GFR down to 20. So the GFR threshold may even decrease more to 20 to initiate an SGLT2 inhibitor. Now, regarding the glycemic effects in patients without diabetes, there was no reduction in HbA1c, 0% compared to placebo, 0.0. There were no hypoglycemias in patients without diabetes in a DAPA-CKD trial. So the drug is safe from a glycemic perspective. And how is that possible? I believe that although you start to lose glucose, because these non-diabetic patients also lose glucose, there's some glycosuria, less than in diabetics, but there's still glycosuria. I think that's compensated by gluconeogenesis in the liver that has been shown in non-diabetic individuals by studies from Ralph DeFranco, demonstrating that the liver increases gluconeogenesis to compensate for the glucose loss in the urine.
Okay, great, Hiddo. It's 8:27. I have one more question. Maybe we'll make this the last one. This comes from Dr. Cunard, who's another nephrologist here at UCSD. She asked, would you treat a diabetic patient with low-grade proteinuria and no evidence of worsening GFR? What about the patient with stable GFR?
We are using these drugs to prevent progression. So from a kidney perspective, I don't think that patient doesn't need an SGLT2 inhibitor, because if there's no progression, there's no place for an SGLT2 inhibitor to slow the progression. And I'm saying that because we have collected data in the DAPA-CKD trial in patients before they started entered the study. So we've asked doctors to register the eGFR data in the medical from the medical electronic database. And if we select patients with no GFR decline before the trial, there's also no effect on GFR, which is perhaps logical. But you should not only look at the kidney, because we should look at the body, and we should also think about heart failure, about cardiovascular events, about mortality, about other risk factors these patients have. So although the patient may not progress, maybe an SGLT2 inhibitor is still indicated to prevent heart failure or to prevent cardiovascular disease. So I understand that, and I'm doing the same. We look at the kidneys, but look at the person, look at the patient, and also think about the other organs.
Wonderful, Hiddo. I just want to thank you again. This was a real tour de force, and it is so incredibly exciting to see these drugs, not only the SGLT2s, but the other medications you described, and the new tools they give us to help not only our patients, but your patients and everyone else's around the world. And it's a real gift to have you come and teach us from your experience. I really appreciate it.
Thank you very much. It was a pleasure to be with you this morning, and I wish you a nice day. My day has finished now.
Thank you
Great.
so much.
Thank you.
Hiddo, that was terrific and really, really well received. We had, I think, about 100 or so of our faculty here.
Wow, yeah.
Which is
it's a lot. It's a lot.
So.
Yeah. Thank you very much again. I really enjoyed it, and I like the question and answer session.
Wonderful. at some point we should circle back around your biomarker work. I know that there was an abstract that was presented, but I'd love to know what
Yeah,
the next
very
steps are.
good point, Joe. That was a little bit difficult. Remember to interpret the data. Some of
Yeah.
these biomarkers went down and others went up. So it's funny because you bring this up. I finally got the AKI data from the Canvas trial. And I think it's much nicer to look at these biomarkers in combination with AKI events.
Yeah.
So we are running the analysis right now. And I said to the guys who are doing the analysis, let's just replicate Joe's paper in Kidney International from the SPRINT trial first as a starting point, because you nicely showed how these tubular damage markers correlate with AKI in SPRINT, what the changes in the biomarker in a patient with an AKI event versus no AKI event. So they are doing that now. They're creating the tables. I think it will take them 1 or 2 weeks. And let's then schedule a telephone call and then try to make something. And then we can look at what other analyses are required.
That would be great, because every time I give a talk around that topic, the first question is, what about SGLT2 inhibitors, right? So
Okay.
I think
Yeah,
there's a lot
okay.
of interest about,
Yeah.
what can we tell?
Yeah. So as soon as we have the tables and figures ready, I will send those to you, and we'll schedule a team or a Zoom meeting, and we can discuss this. Okay.
Great.
Yeah.
Hiddo, last thing, if you're coming in November, I know how busy you are, but if you want to come a day ahead, or if you have a half day, maybe we could sit down and just have some white space and sketch ideas.
Great.
That would be really terrific.
Yeah.
So let me know. I'm happy to host you and what have you, but it would be really great.
Yeah, would like to do that. Yeah. Well, I'll keep it in mind.
Okay, great, Hiddo.
Right.
Thank you very, very much. This was wonderful.
Thank
you so much. Thank you, Dr.
Bye.
X. Thank you, Eric.
Thank you, Margaret. Appreciate it.
Bye-bye, Margaret.
Bye-bye.